Module 13 is about endocrine disorders. First, we're going to have a brief review of anatomy and physiology. So the endocrine system regulates growth and development, energy use and storage, levels of glucose, fluid, and sodium in the bloodstream, sexual development, and the child's response to stress. The endocrine system consists of organs that produce and secrete hormones. So hormones are chemicals that are produced by these endocrine glands and circulated in the bloodstream to another part of the body. They either activate or inhibit cells in the target organs and act as messengers. The endocrine system communicates using positive and negative feedback systems of communication. Positive feedback happens when hormone levels start to decline, which causes the hypothalamus to secrete hormones that stimulate the pituitary gland and release more hormones that affect the target organs. Negative feedback occurs when hormone levels are too high. The hypothalamus secretes inhibitory hormones that stimulate the pituitary gland to release inhibitory factors. So talking about some of the glands of the endocrine system, the hypothalamus is located at the base of the brain. The hypothalamus sends messages from the autonomic nervous system to the target organs by secreting, releasing, or inhibitory hormones to the pituitary gland. So the hormones that the hypothalamus secretes include the thyroid-releasing hormone, corticotropin-releasing hormone, luteinizing hormone-releasing hormone, growth hormone-releasing hormone, and somatostatin, which stimulates the pituitary gland to stop the release of growth hormone. Then we have the pituitary gland. The pituitary gland is also called the master gland, and it's located beneath the hypothalamus in the base of the brain. This gland controls other glands through stimulating hormones or inhibitory factors that turn the target glands on or off. The pituitary gland does have two main lobes. So the anterior lobe secretes growth hormone, which stimulates growth of cells, thyroid-stimulated hormone, which stimulates the thyroid gland to make thyroid hormones, adrenocorticotropic hormone, or ACTH, stimulates the cortex of the adrenal glands to make cortisone. Prolactin stimulates milk production. Follicle-stimulating hormone stimulates the ovaries to develop eggs. Luteinizing hormone stimulates the follicles and the ovaries to rupture and release the eggs, and also stimulates testosterone production in males. Melanocyte-stimulating hormone stimulates melanin synthesis and release from skin and hair. Then in the posterior lobe, it secretes antidiuretic hormone, also called vasopressin, that stimulates the kidneys to absorb and conserve water and increases blood volume. And then oxytocin or pitocin stimulates smooth muscle contraction and milk letdown. Then the pineal body is located in the middle of the brain. It's stimulated by light exposure through the optic nerve. This one secretes the hormone melatonin and regulates the sleep-wake cycle and circadian rhythms. The thymus is located at the base of the heart in the chest, and it atrophies with age, and it is responsible for cellular immunity. The thyroid gland consists of two lobes in the anterior neck region, just below the larynx. It produces T3 and T4 in response to TSH being released from the pituitary gland. So the pituitary gland releases TSH, and that in turn causes the thyroid to produce T3 and T4. They're responsible for synthesis of protein and cholesterol, glucose metabolism, heat production, growth and development, and metabolism. It also secretes calcitonin, which stimulates bone construction by inhibiting calcium release from the bones and decreasing calcium blood levels. We also have the parathyroid glands. There's a total of 4 of them, 2 on each side of the thyroid gland, and they produce parathyroid hormone, or PTH. It increases calcium concentration in the bloodstream, increases serum calcium levels by increasing the absorption of calcium from the GI tract, and increases calcium reabsorption in the kidneys. It also increases phosphate release from bones, increasing the blood levels, and inhibits phosphate reabsorption in the kidneys so that more phosphate is excreted. Then we have the adrenal glands. They're located on top of the kidneys. They are made up of two parts, the cortex and medulla. The cortex produces steroids like glucocorticoids, mainly cortisone, which increases blood sugar, decreases inflammation, and aids in stress reduction. It also produces aldosterone, which is secreted to conserve water as well as sodium. The medulla produces epinephrine and norepinephrine, which are responsible for the flight or fight response, which increases heart rate, respiratory rate, dilates the pupils, increases the utilization of glucose, and suppresses digestion and the immune system. It also secretes dopamine, which helps increase blood pressure. The pancreas has both exocrine and endocrine function. Exocrine function consists of secreting amylase, lipase, and trypsin for small intestine digestion. And endocrine function consists of beta cells secreting insulin, which forces glucose into the cells and stimulates glycogen formation. This is independent of any pituitary control and is stimulated by the ingestion of glucose. Alpha cells work in the opposite manner as insulin. They break down glycogen in the liver to increase blood sugar. The gonads, also called the sex glands, include the testes and the ovaries and are responsible for the regulation of puberty and fertility. The testes produce androgen, mainly testosterone, in cells when stimulated by FSH and LH. Testosterone produces the secondary sex characteristics in males, and also sperm formation and sex drive. The ovaries produce estrogen and follicle cells, so estrogen produces secondary sex characteristics in females and mammary development. Follicle cells produce corpus luteum, which means yellow body, which makes the hormone progesterone after the egg leaves the follicle. Progesterone maintains pregnancy by relaxing the uterus and also stimulates milk production in the mammary glands. When a woman is pregnant, the ovaries and uterus produce relaxin, which is a hormone that relaxes the cervix, vagina, and ligaments around the birth canal in preparation for delivery. And also, human chorionic gonadotropin hormone is produced by the developing embryo. It inhibits the immune response to the developing fetus. On assessment, we can inquire about things like their birth history, prenatal care, estimated gestational age, were there any complications or substance abuse, or any complications after birth, any hospitalizations, any surgeries, what current medications are they on, including OTC and supplements? Do they have any allergies, medications, seasonal, food, any other allergies as well? Are they up to date on their immunizations? Any family history of endocrine disorders or things like extreme short stature? What are the heights of their parents and their siblings? And is there any history of any other chronic diseases in the family? What's their developmental history? So are they meeting their milestones or did they in the past? Any history of behavioral problems or school performance problems? Nutrition-wise, what type of infant feeding are they on, as in formula or breast? What's their diet history for 2 to 3 days past? Eating patterns, type and frequency of things like milk, fast food, any eating related issues like vomiting or GI distress, and any problems with chewing, swallowing, drinking, anything like that. What is their activity level, including their daily activities, their physical activities, how much time do they spend playing video games, for example. When we're talking about when reviewing their different systems, we can do things like doing their height and weight, their OFC if it's a baby or a small toddler, and of course their vitals. We can also assess which stage of puberty they're in using the Tanner stages of puberty, which is assessing things like do they have armpit hair, do they have breast buds, etc. We can also assess for signs of ambiguous genitalia. Skin-wise, we can assess for skin discoloration or any increased pigmentation. Body odor, are there any unusual smells like fruity or musty smells? Looking at the neck area, are there any enlarged lymph nodes or glands that we can feel? Musculoskeletal-wise, what is the strength and tone of their muscles? Is there any excess fat accumulation or decreased muscle mass? And facial characteristics, we can assess for any unusual facial features such as a protuberant tongue, bulging eyes, excessive hair growth, or excessive roundness of the face. Growth hormone deficiency is a form of hypopituitarism where the growth hormone is not sufficiently secreted because of damage to the gland, to the pituitary gland. So this can occur as a result of trauma to the head during delivery or later in life, brain tumors, infectious disease in the CNS system like meningitis, chemotherapy, radiation, surgery, and congenital syndromes. So this was formerly known as dwarfism or pituitary dwarfism. It results in a person with a short stature but with normal body proportions. On assessment, the child will have delayed growth of less than 2 inches per year with a constant declination of growth measurements over time. They could also have, as a baby, a delay of closure of the anterior fontanelle, increased abdominal fat, delayed dental eruption, decreased muscle mass, a cherubic-like appearance where they appear younger than their age, delayed puberty, and a high-pitched voice. To test for growth hormone deficiency, we can conduct a thorough review of growth charts and a review of parents' heights. So particular attention is given to those children whose growth is less than the 3rd percentile on growth charts. We can also do bone age x-rays of the left hand and wrist. So that's used to determine the actual age of the child's bones in comparison to the child's actual chronological age. So if their bone age is greater than 2 standard deviations below normal, it merits further evaluation by the provider. We can also do an MRI of the head or the brain, specifically focusing on the pituitary gland to see if there's any abnormalities of the gland. We can also do provocative growth hormone testing. This test uses certain medications that stimulate the pituitary gland to make growth hormone. We can also rule out Turner syndrome in girls, do thyroid function tests, ACTH and cortisol levels, rule out renal failure, which is sometimes short stature can be caused by chronic renal failure, and also ruling out inflammatory bowel disease and celiac disease, which can also inhibit children's growth. Interventions, we can continue close measurement of the child's growth, so continuing to plot their height and weight on growth charts and monitoring that even more closely than we would normally. The child can also be prescribed growth hormone replacement therapy, and this is best to be started as soon as possible. So growth hormone replacement therapy consists of daily subcutaneous injections of manufactured growth hormone, which is called somatropin. So there's a picture of it on the slide of one of the brands at least. that it comes in a pen that's sort of like an insulin pen. So it can be very easy for the child or their parents to administer it to them at home since they do have to have it daily. It's dosed differently depending on what the manufacturer is, and some side effects can include things like headache and then pain in the joints and muscles. Hyperpituitarism or growth hormone excess is a rare condition that's characterized by excess growth hormone secretion from the pituitary gland, which causes children to experience uncontrolled growth. If the patient has precocious puberty in conjunction with hyperpituitarism, the condition may be caused by a tumor on or near the hypothalamus or the pituitary gland. So once closure of the growth plates occurs and hyperpituitarism continues, then overgrowth of the bones occurs, which is referred to as acromegaly. So on assessment, the child can have characteristics like enlargement of the hands and feet, coarseness of facial features, including the forehead, nose, lips, tongue, and jaw are common. Other symptoms can include generalized muscle weakness and pain in the muscles and joints. Diagnostic testing for growth hormone excess includes monitoring growth trends, especially if the child does have excessive growth and is over the 95th percentile. We can also test for IGF-1 levels. They will be elevated with hyperpituitarism. IGF is insulin-like growth factor. We can also do bone age x-rays, which can show an advancement of bone growth, and then an MRI of the brain to rule out any tumor. Interventions consist of administering growth hormone receptor agonists, somatostatin analogs, and dopamine agonists. These are all prescriptions that can be given at home. We can continue to monitor growth trends and assess lab results. We also want to educate the patient and family on long-term complications of non-compliance, such as hypertension, cardiomegaly, cardiovascular disease, diabetes, osteoarthritis, sleep apnea, and early death. Diabetes insipidus is an insufficient production of antidiuretic hormone, which is stored in the posterior pituitary gland, and it acts on the kidneys to restore water and control the amount of urine excreted. There's two forms of diabetes insipidus, central and nephrogenic. Central diabetes insipidus is caused by insufficient ADH production. So this can occur from things like brain tumors, infections, brain injury, or it could be idiopathic and have no known cause. Nephrogenic diabetes insipidus is where the kidneys fail to respond to appropriate levels of antidiuretic hormone. This could be caused by things like medications, such as lithium or clozapine, sickle cell anemia, and pregnancy. On assessment of someone with diabetes insipidus, they will have polyuria, so a lot of urine output, polydipsia, they're always thirsty. They could have enuresis, which is nighttime bedwetting, constipation, fever, dehydration, hypernatremia, getting up to drink water during the night, irritability in infants that's only relieved of giving water instead of milk. So severe hydration can occur very quickly in infants and small children. So we need to recognize and teach parents to recognize things like dry mucous membranes, sunken fontanelles, tachycardia, minimal or absent tears, and decreased skin turgor. Testing of diabetes insipidus consists of measuring a 24-hour urine collection to measure the daily output of the patient. We can also look at serum sodium. Is it elevated? typically greater than 150 up to 170 milliequivalents per liter is indicative of diabetes insipidus. We can also look at the urine osmolality and urine specific gravity, and they are usually decreased. We can give the patient a water deprivation test, which is used to diagnose diabetes insipidus. So with this test, the patient's under direct supervision by the nurse or provider, while the nurse carefully monitors vital signs and the patient's weight. Urine and blood are collected early in the day and tested for osmolarity and electrolytes. Then the kid is deprived of water intake until significant dehydration occurs. The child's weighed about every 2 hours until 2 to 5% of body weight is lost. Urine-specific gravity is monitored every hour, and then the test is stopped once the urine-specific gravity reaches a certain threshold. Nursing interventions, we need to have strict intake and output. We also need to monitor vital signs for dehydration and continued assessment for other symptoms of dehydration. They will also be on IV fluid replacement if they are dehydrated. We also need to educate caregivers on signs and symptoms of dehydration and how to administer their medications. So the most common medication given is DDAVP, which is basically synthetic ADH or synthetic vasopressin. So we use this for central diabetes insipidus. It's given intranasally as a nasal spray. It can also be taken orally in a pill or also sub-Q. But obviously for children, a nasal spray is very easy to use. We don't want the child to use that if they have a severe cold or nasal congestion, obviously because they're not going to absorb the medication properly. Interestingly, diuretics can also be used for central diabetes insipidus because they paradoxically decrease urine volume as much as 75%. Syndrome of inappropriate antidiuretic hormone, or SIADH, occurs in the presence of excessive ADH production. The kidneys are then unable to conserve appropriate amounts of water, so the body starts to retain water, which can lead to water intoxication, hyponatremia, and edema. SIADH could be caused by things like CNS infections, like meningitis, brain tumors, head injuries, and can also occur as a post-op complication in some patients. The signs and symptoms have varying degrees of seriousness, but on assessment, the patient could have low urine output or oliguria, nausea and vomiting, seizures, irritability, combativeness, hallucinations, confusion, stupor, coma. Also things that go along with excessive retaining of water, things like increased blood pressure, jugular vein distension in the neck, crackles in the lungs, weight gain, but they may have no visible edema, decreased urine output despite a high urine-specific gravity, and like I said before, low sodium. Testing for SIADH would show low serum sodium and osmolarity, decreased BUN and hematocrit, and high urine-specific gravity and osmolarity. The number one intervention for SIADH is going to be fluid restriction. If they do need fluids because of hyponatremia, we would give them a hypertonic sodium chloride solution. Corticosteroids, strict intake and output, and a diet high in sodium and protein. They may also need to be on seizure precautions, and we need to do frequent neuroassessments if their sodium is less than 125 because they're at risk for having seizures. We also want to educate the parents on fluid restrictions and hidden sources of water, things like watermelon, and also how to calculate intake and output at home. We can also educate on signs and symptoms of sodium depletion, when to go to the doctor, and possibly wearing a medical alert bracelet. Hypothyroidism is caused by an underactive thyroid gland. The thyroid gland produces the hormones T4 and T3. Hypothyroidism can be congenital or acquired. With congenital hypothyroidism, most infants are usually born asymptomatic at birth, so they may have no symptoms, but they may start to develop these symptoms within a couple weeks to months after birth. Symptoms for these babies include low tone, lethargy, an open posterior fontanelle, open cranial sutures, an umbilical hernia, prolonged jaundice, paleness, enlarged tongue, hoarse cry, constipation, dry skin, respiratory difficulties, poor weight gain, edema, goiter, abdominal distension, and an increased birth weight. Acquired hypothyroidism presents later in the child's life, in their childhood or teen years. The onset could be related to an immune condition known as Hashimoto's thyroiditis. Medications can also cause it, such as lithium, that interfere with thyroid synthesis. Symptoms could be decreased appetite, thinning of the hair or losing hair, dry, cool skin, depressed tendon reflexes, bradycardia, constipation, extreme fatigue, sensitivity to cold, abnormal menstrual cycles. They can also have a deceleration in their growth. They could have a weight increase, delayed bone age, delayed dentition, muscle weakness, and delayed or precocious puberty. School-age children may also start to show a decline in their school performance. They may also have a goiter on their neck. Diagnostic testing-wise, thyroid laboratory tests are part of the newborn screen in all states to test for congenital hypothyroidism. In children with suspected acquired hypothyroidism, we can test for T4, TSH, and antithyroid antibodies. We can also do a thyroid ultrasound to see if there is anything wrong with the thyroid gland. And we can also plot the child's growth velocity on growth charts. Nursing interventions, we can give thyroid hormone replacement, such as levothyroxine. We want to continue to monitor their growth by plotting it on growth charts. And we want to educate caregivers about the need for lifelong medication and follow-up. So basically, they're going to need to be on levothyroxine or whatever is prescribed to them for the rest of their life. So we need to educate on how to give this medication. We need to look out and instruct parents on the potential of myxedema, which is a severe complication when the thyroid levels are extremely low. This can cause non-pitting edema around edematous face, edema of the tongue, metabolic disturbances, and hypothermia. So if left untreated, this could lead to cardiovascular arrest and coma. Hyperthyroidism or Graves' disease is the overproduction of thyroid hormones. It occurs most frequently in teens between 12 and 14 years old, and it tends to be familial. If untreated, hyperthyroidism could cause lifelong complications to different body systems, especially the eyes, central nervous system, and the GI tract. Thyroid storm is a life-threatening condition that requires medical intervention and hospitalization. It could occur if the symptoms go untreated for a long period of time and become severe. Clinical presentation of this would be possibly a goiter in the neck, along with exophthalmos or bulging of the eyes, as shown in this picture. Other symptoms include restlessness, fatigue, tachycardia, high blood pressure, sweating, increased appetite, weight loss, difficulty sleeping, tremors, intolerance to heat, fine hair, murmurs, absence of menses, and mood changes or irritability. To test for this, we can test and see that there's elevated T3 and T4 levels, and then there would be lower undetectable TSH levels. We can also do a thyroid ultrasound to look for nodules or enlargement. Interventions, the patient could be placed on medications such as beta blockers or other antithyroid agents such as propylthiouracil. They could also be prescribed radioactive iodine therapy. And they could also have surgery to remove overactive nodules or a total thyroidectomy. If they do have their entire thyroid removed, then they would need lifelong thyroid replacement. Congenital adrenal hyperplasia, or CAH, is the inability to produce cortisol in the adrenal glands caused by excessive amounts of corticotropin releasing hormone, or CRH, and adrenocorticotropic hormone production, ACTH. Because of the surplus of these two hormones, the adrenal gland begins to develop hyperplasia or become larger, which leads to excessive androgen hormone production from the adrenal glands. Um, on assessment, the child is at risk for dehydration and hyponatremia because of these low cortisol and aldosterone levels. In males, they don't experience manifestations until later in childhood, where they could have early development of pubic hair, enlargement of the penis, advancement in growth velocity, and advanced bone age. Females, however, manifest symptoms at birth with ambiguous genitalia. They could have an enlarged clitoris, fused labial folds, but they would have normal internal sex organs. So they would have ovaries and a uterus, for example. To test for this, we can do blood tests of the different hormones, and we need to do chromosomal analysis to determine the sex of the baby if they do have ambiguous genitalia. We may need to refer the parents to genetic counseling if they do plan on having more children, since this is inherited. Intervention wise, again, we want to monitor for dehydration and electrolyte imbalance and any hypovolemic shock. They will need corticosteroid administration daily for life because their cortisol and aldosterone is going to be low. We need to do frequent cardiopulmonary assessments and vitals because of the risk for dehydration and electrolyte imbalance. We need to assess the parent's emotional status regarding ambiguity of the infant's genitals and take into account any cultural or religious beliefs. We also need to educate caregivers on medication administration, including stress dosing. So stress dosing is where we would double or triple their steroid dose during times of stress, such as if they need to have surgery, if they are sick with the flu, for example, if there is any sort of emergency. So basically, anytime the baby or child is under any sort of stress physically, we would double or triple their steroid dosage. We also want to refer to support groups in the area. Type 1 diabetes mellitus is caused by destruction of the beta cells in the pancreas. When the beta cells are destroyed, the pancreas can no longer produce insulin, so glucose levels in the bloodstream are too high. So kids with type 1 diabetes must have insulin administered to them to survive. The cause of diabetes results from a variety of things, including possible genetic influence, autoimmune mechanisms that negatively affect the pancreatic cells, and also viral illnesses that destroy pancreatic function. On assessment, the child would have polyuria, polydipsia, and polyphagia. They could also have unintentional weight loss, high blood and urine glucose levels, nausea and vomiting, excessive fatigue, abdominal pain, increased susceptibility to infections, dehydration, blurred vision, irritability, and restlessness. If we were to test the patient's blood glucose level, it would probably be greater than 200. Their hemoglobin A1C would be greater than 7.0. They would have decreased serum insulin levels and the presence of serum and urine ketones. Interventions for type 1 diabetes, of course, include administration of insulin. So in the hospital, when we're administering insulin, we need to double check it with another RN. So not only having them visually check it, but at most places they also have to sign off on the patient's chart that they checked it as well. We only want to use insulin syringes when we're administering it because, of course, we're administering it in units and not milliliters. We want to store the insulin per manufacturer recommendations, whether that means at room temperature or in a refrigerator. We want to rotate the injection sites, for example, on the abdomen or the back of the arm or the thigh or the butt, or sometimes whatever the patient prefers. We want to monitor daily weight and assess the patient's blood glucose per orders and before sliding scale administration if that is applicable. We also want to monitor for diabetic ketoacidosis, which could present with things like Kussmaul breathing patterns, and we would need to administer IV fluids and IV insulin. We can also place a dietary consult and place the patient on a diabetic diet. We can teach them how to do carb exchanges or defer that to dietary. We can assess their activity level and the need for extra carbs and protein before exercise and sports. So if the child is very active, we need to be aware that they could become hypoglycemic more readily than someone who is not. We can assess laboratory values such as phos, mag, and potassium because insulin may decrease serum levels of this. We want to monitor their hemoglobin A1C over time. We, of course, need to teach the family and the patient how to administer insulin, how to check the blood sugar, and how to test the urine for ketones. We also want to teach signs of hypoglycemia and when to administer glucagon or glucogel. So glucogel is going to contain glucose and it can just be squirted basically into the patient's mouth. But in order for them to have that, they need to be conscious. So if someone is unconscious and we think that they may be hypoglycemic, then we can administer glucagon, which is an IM injection where they get 1 milligram or 1 milliliter injected into them intramuscularly. But if they're unconscious, we don't want to put anything in their mouth. We also want to refer them to support organizations such as the Juvenile Diabetes Foundation. Type 2 diabetes occurs when the body becomes resistant to insulin production from the pancreas. Type 2 diabetes is also sometimes called adult onset diabetes. However, pediatric obesity has led to a sharp increase in type 2 diabetes among children and adolescents. Risk factors for type 2 diabetes are obesity, sedentary lifestyle, family history of diabetes, and poor dietary intake, especially high carb, simple sugar foods. On assessment, many children with type 2 diabetes have no symptoms, and the condition is sometimes diagnosed with routine well-check visits. But any child with a BMI more than the 85th percentile for weight and age should be monitored for early signs of type 2 diabetes because obesity is a key predisposing factor. They can also have something called acanthosis nigricans, which is a dark pigmented area on the back of the neck, the armpits, and the arms, and is evidence of insulin resistance. The child may eventually have gradual symptoms of burning sensation in the feet, ankles, and legs, poor wound healing, changes in vision, and fatigue. Testing wise, they may have an elevated fasting blood glucose of over 125 and a random blood glucose of over 200, a hemoglobin A1C of greater than 7.0, and we can also do oral glucose tolerance testing. Interventions for type 2 diabetes include taking a dietary history and referring to a dietitian for counseling if needed. We want to encourage exercise and weight loss if that is applicable. We also want to involve the entire family in dietary and exercise education. It's going to be very hard for a child to try to lose weight and eat healthy if their entire family is doing the exact opposite. We also want to administer anti-hyperglycemic medications, so that could be things like metformin or glyburide and or insulin if applicable. We want to educate the family regarding long-term complications of type 2 diabetes, such as heart disease, hypertension, high cholesterol, and vision damage. We want to teach signs and symptoms of complications such as hypoglycemia, hyperglycemia, and DKA. Insulin pumps can be a really great intervention for children, most notably with type 1 diabetes. But what it is a small computerized device that delivers insulin in two different ways. So it can deliver a basal dose, which is a steady, continuous dose of insulin around the clock. And it can also deliver a surge, which is like a bolus dose at the patient's direction, usually around mealtime. Insulin pumps use regular insulin, such as Humulin R, for example, which is a fast-acting insulin. They do need to remove these prior to MRI, so something to take into account if the patient is going to be in the MRI for an extended period of time. There are many different brands of insulin pumps. Some of them now continuously monitor blood sugar and can send information to parents' phones as an alert. And this may be easier for some kids while they're at school, while they're playing sports, and can allow for more restful sleep.